Hello to everybody. Thank you very much for inviting me. I'm Chiara Robba from the University of Genova, and I will discuss with you today about the potential use of brain monitoring in the ICU settings. So not in neurocritical care, but in all the other settings of general intensivists. So, neuromonitoring is basically part of a very important concept, which is the multimodal neuromonitoring tools. And as you can see from this slide, there are a huge number of types of neuromonitoring that can be used to assess the brain. If you ask me which is the favorite neuromonitoring tools, I would say that I don't know, because it really depends on the question that you're asking to the patient, to the brain of the patient, because each type of neuromonitoring tool is able to determine and to provide information regarding flow, metabolism, pressure, etc., etc. Now, the good thing is that each type of neuromonitoring tool itself cannot provide all the information that we need because each type of neuromonitoring is correlated with the others. There are those which are influenced more by the cerebral oxygenation, but these are strictly correlated, for example, to the intracranial pressure. And the same thing regarding, for example, the flow velocity of the transcranial Doppler and the cerebral blood flow velocity or the cerebral blood flow, as well as the metabolism. So every time that we use a neuromonitoring or that we study a brain, what we need to do is to assess the physiology, to assess the effect of what we do to the patient on the cerebral physiology. But at the end of the story, what we need to achieve is a therapeutical plan which is based on neuromonitoring, because neuromonitoring itself just provides information, just provides a number which has to be integrated in the clinical picture of the patient. And one example, and I give you this example because it's the most studied, is the use of intracranial pressure. And as you can see, for intracranial pressure monitoring, there are a number of clinical recommendations of algorithm for the application of intracranial pressure in the clinical practice, in the management of TBI. This is the very famous consensus, the Seattle consensus, where a large number of experts sat down and decided how to manage the patient according to the intracranial pressure. The ideal thing is to have algorithm like this considering multimodal parameters. Research has still to work a lot on this, but we are already at the moment when we have some evidence which can help us in the management of these patients. And even the neuromonitoring tools that until few years ago were considered forbidden or too difficult for the intensivist are gaining interest in the ICU settings. One example is the continuous quantitative EEG. This is a study which basically demonstrated that after a small training of 2 weeks, even intensivists are able to assess symmetry, sedation, artifacts, and the presence of seizures in patients in the ICU, which were monitored with continuous quantitative EEG. So the technology is making our life easier, are helping us to understand in a more simple way the difficulties of assessing difficult factors such as the cerebral metabolism and physiology. Now, which is the near future, but it's also the present. All these neuromonitoring tools have been mainly studied in the neurocritical care settings. And this is obvious because neurointensivists are more keen to study the brain. But the reality is that in the near future, and what we are doing now is to implement brain monitoring in different settings, for example, in the emergency department, in the general ICU, in the operating room, because as I'm going to show you in this presentation, there are a number of indications and a number of clinical situations where the patient is not primarily brain injured, but the risk of cerebral complications is very, very high. And so neuromonitoring tools can really help us. And when we talk about the setting of ICU, so not brain injured patient, primarily brain injured patients, obviously the non-invasive methods are those which have gained more interest because there is not the indication to be invasive to do a hole in the brain of the patients, in a patients with sepsis or with cardiac arrest. But still, we have a number of non-invasive methods which can provide us a lot of information regarding flow, pressure, oxygen, metabolism, etc. There are a number of important a number of clinical examples where neuromonitoring the neurocritical care settings will be of great importance. Just think about the post-cardiac arrest syndrome. Most of the patients with cardiac arrest die of cerebral edema, and so we are used to monitor the heart, to monitor the lung, but we are not very used to monitor the brain, which is one of the major causes of disability and mortality in this context. Sepsis, think about all the neurological complications in a patient with sepsis, pregnancy, encephalopathies related to pregnancy, liver failure, and also mechanical ventilation. So even in very, very simple cases, the use of neuromonitoring can really help us to reduce the complications. An example, as I was mentioning, is the use of protective ventilation. We have published a number of studies regarding this that I'm going to show you. And basically the concept is that if we want to be protective with the lung, often we are not protective with the brain. So the use of protective ventilation, so low tidal volumes, permissive hypercapnia, can be good for the lung because it reduces the risk of VILI, but it can be detrimental for the brain. So the question is, why don't we start to monitor also the brain in these patients? This is what we have done, for example, during the COVID pandemic. So no brain injury patients, but as you know, patients with a high risk of neurological complications. And we use neuromonitoring tools for the assessment of ICP and of cerebral oxygenation in patients, for example, who underwent prone positioning or recruitment maneuver. These are the results, for example, for prone positioning. And as you can see, a maintenance of the mean arterial blood pressure during prone position led to an increase of intracranial pressure, but despite this, an improvement of the cerebral oxygenation. And this is another example, for example, during the use of nitric oxide, where the vasodilation caused an increase of the cerebral and of the systemic oxygenation with a small increase again of the intracranial pressure. Recruitment maneuver, this is a very important point. We found that recruitment maneuver in patients with COVID-19 could also improve the systemic oxygenation, but because recruitment maneuver can lead to episodes of hypotension, this could lead to a reduction in the cerebral oxygenation values here, despite the systemic oxygenation does not change, and an increase of intracranial pressure. And again, we used a lot during the pandemic carbon dioxide removal. Carbon dioxide removal is good to reduce very quickly the CO2, but what we have noticed is that if we reduce too quickly the CO2, this results in a reduction of the cerebral oxygenation. And this is probably related to the fact that there is a quick vasoconstriction at the arterial level related to the reduction of carbon dioxide. So we have to think about two organs when we use mechanical ventilation, lung protective strategies. And this is what we highlight in this editorial when we say that we have to use a combined lung and brain individualized lung protective ventilation strategies. And what does it mean? In this study, we propose, in fact, that when we set the PEEP, when we do the recruitment maneuver, we use the ultrasound not only to set the PEEP according to the lung needs, but also to the cerebral needs. This is an example. This is a brain ultrasonography study in a patient who underwent a recruitment maneuver. And as you can see here, what happens is that there is an increase of intracranial pressure, which is detected using brain ultrasonography. This is the optic nerve sheath diameter, which gets enlarged during the recruitment maneuver. This is the MCA flow velocity, where the pulsatility index increases, and this is the venous flow, where the pulsatilities in the venous components increases, which means that there is an increase of intracranial pressure. And on the base of this, we have started to propose some algorithm for combined brain and lung protective ventilation, which in reality is very simple. It also only says, well, if you have to set the PEEP, if you have to increase the intrathoracic pressure, consider the lung needs, but also put a probe on the brain and see what happens to the brain and set the level of PEEP and the need for recruitment maneuver also regarding and based on the need of the brain, because otherwise the risk of cerebral complications increased. Another very simple example is in this physiological study. We all know that passive leg rising test is a good test to assess fluid responsiveness. We don't know which is the effect on the brain. Here we used different types of hemodynamic maneuvers, passive leg rising test, and then we did fluid bolus or norepinephrine according to the patient's clinical need. And as you can see here, what we noticed is that despite the map did not significantly change among the three groups, there was an important increase in cerebral oxygenation in the group which used norepinephrine or also fluid bolus compared to passive leg rising test. And the reason is simply that passive leg rising test, according to this physiological study, can impair the cerebral autoregulation and therefore can have a lower beneficial effect on the cerebral oxygenation. And this can help us in the decision to use one maneuver or the other one in the manipulation, in the systemic manipulation, hemodynamic manipulation of these patients, also considering the brain's need. And this is, in fact, what we have found, especially in the COVID-19 population, which was perfect for this purpose, because they were all patients who needed lung protective strategies. And what we did was to use neuromonitoring tools in this population. And we found that a huge number of these patients had alteration in pupillometer values, in intracranial pressure measured with transcranial Doppler, etc., and that the alteration of these factors, of cerebral factors, was independently associated with a higher risk of ICU stay and mortality. Another example is the use of neuromonitoring in sepsis. This is not the standard of care, but there are a number of studies which are starting to highlight the fact that in patients with sepsis, there are important cerebral alterations. This is a pilot study which basically used the transcranial Doppler in septic patients. And what the authors found here was that patients who developed septic encephalopathies after the acute phase of the sepsis were those who had the higher values of pulsatility index and altered values in the flow velocity. So this means that probably we don't focus too much on the brain in these patients, even though this can be of great clinical importance. Same thing for the sepsis. This is a systematic review which assessed the neurophysiological assessment in these patients. 17 studies were found in this systematic search where EEG was used in this population, and the results are basically these. First of all, EEG alterations during sepsis are very, very common, and the patients who have EEG alteration are those who are more likely to develop neurological complications. So using a standardized neuromonitoring, multimodal neuromonitoring tools can really help to early detect the presence of cerebral complication and potentially improve the outcome. Now there are other more sophisticated and new neuromonitoring tools. So one example is the pupillometry. This is a retrospective study which was done by the group of Fabio Taccone, and as you can see here, there is a not very strong, because the sample size was small, but there is anyway a correlation between the values of the MPI from the pupillometer and the value of MX, which is the index of autoregulation. So pupillometer is a very easy tool which can be used at the bedside, and actually this study demonstrated that can give us an idea of impaired or intact autoregulation in these patients. And now let's think about the possibility to integrate what we have said in the clinical practice. If you think about the FAST protocol, the focus in trauma, the patient arrives in the emergency department or in the ICU, and we are now used, because the guidelines are telling us that we have to do an ultrasonography of the heart, of the lung, and of the abdomen. But think about just moving the probe a bit higher, higher than the shoulders. And let's see if we can estimate cerebral physiology using the ultrasound. We can, because, for example, in a patient with trauma, the number of information that we can get from neuromonitoring are very important and very quick. We can have information about the presence of midline shift. We can have information about the cerebral blood flow. We can have information regarding the intracranial pressure. And the same thing, what I was mentioning before in the cardiac arrest. Here in this review, we proposed to add the focus in cardiac arrest, even adding the part regarding the brain, which can provide very early information regarding intracranial pressure and the cerebral perfusion, which then is related to a high number of potential cerebral complications. And still in cardiac arrest, other types of neuromonitoring tools have been proposed. One is very simple, it's the NIRS, the cerebral oximetry. This is a study which was published on resuscitation, a feasibility study regarding the role of cerebral oxygenation in predicting the return of spontaneous circulation in cardiac arrest. And what the authors found is that, first of all, NIRS does not interfere with the management of cardiac arrest patients. And secondly, is that patients who had the ROSC had significantly higher overall values of cerebral oxygenation. So this means that this tool can be eventually be used to predict the ROSC and to optimize the cerebral perfusion during the early phases of cardiac arrest. These are, in fact, the results. You can see that the survivors had higher values of cerebral oxygenation than the survivors immediately and in the first 5 minutes from assessment. Same story regarding the perioperative settings. We are intensivists, but we are also anesthesiology, and we manage the patient before, during, and after the operations. And there are a number of possible intraoperative neurological complications. It really depends on the type of the operation, but even in not primarily brain injured patients, the number of neurological complications are very, very high. So is it maybe the time to consider a non-invasive monitoring even during the perioperative settings? I think so. This is, for example, a very interesting study which basically demonstrated that using intraoperative EEG demonstrated that alteration in the intraoperative settings are associated with a very high risk of postoperative delirium. So delirium, you know, is a very important tool, is a very important topic, and is a major issue in the postoperative and in the ICU settings. If we can predict it and we can optimize the cerebral metabolism in the early phase, this can really improve outcome and make our life easier. And this is an example of the use of the cerebral oximetry during coronary artery bypass. And here what the authors found is that the incidence, the relationship between episodes of desaturation during the operation as a magnitude and the number of cerebral desaturation is associated with the development of postoperative delirium. And again, these are non-invasive and very simple tools that can be used at the bedside. But even, let's say, operations which potentially do not seem too harmful, like not cardiac surgery, but even very simple types of surgeries, like shoulder surgery, can lead to cerebral and neurological complications. This is a study that we did using the transcranial Doppler in 23 anesthetized patients undergoing shoulder surgery without neurological complications. And what we found is that at the induction phase, these patients experience a moment of altered autoregulation, which is probably related to a moment of hypotension, and which is probably related to the positioning of the patient, the beach chair position. And even if these patients were all young and healthy, those who developed the more altered autoregulation values or the more altered intracranial pressure values were those who had more delirium and more neurological complication. And another example is this one in a study that we published a few years ago on BJA. These are patients undergoing Trendelenburg position. So imagine a patient who does a prostatectomy and remains for 4 or 5 hours with a head down. What we found is that the induction of pneumoperitoneum and Trendelenburg position and the insufflation of carbon dioxide always causes an increase of the intracranial pressure in these patients. So again, we monitor all the body, but we are not used to monitor the brain, and this can lead to the missing of some complications which can be developed even during routine surgery, even in patients who are healthy and are fine. So, in conclusions, the brain monitoring the ICU, I think, is something on which we really have to work, because neuromonitoring should expand beyond the neurocritical care settings. And as I showed you, there are a number of clinical settings that would benefit from the implementation of brain monitoring. We are used to monitor everything below the shoulder. We only have to do one more step and start to think that there is also the brain, which is a very important organ, which is related to mortality and morbidity. Obviously, this, for implementing this training and implementation of brain monitoring together with other systemic monitoring techniques is warranted. We are still at the beginning of this process. It's not yet in the clinical practice, but I think that what we need to do in the next years is to focus mainly on this. I thank you for your attention, and I am available for any questions. Thank you.